So what is the consensus point for when we shift patient with HFrEF who are on ACE to ARNI? What are the dose equivalents? So particularly, we should consider a few important points here. First of all, the washout period for AC inhibitor is very important. We should, if the patient is already taking AC inhibitor, then we should stop the AC inhibitor. We should allow the AC inhibitor to be washed out from the body, and the time required for this is at least 36 hours. So we should wait for 36 hours after stopping AC inhibitor, then we can initiate ARNI. So in what doses we should start ARNI? So it depends on the dose, the previous dose, the doses of AC inhibitor which the patient was taking. Suppose if the patient was taking an equivalent dose of less than 10 mg, less than or equal to 10 mg of enalapril, or equivalent doses of less than or equal to 160 mg of valsartan, then 50 mg twice daily would be an appropriate dose of ARNI to start. If the patient was taking more than 10 mg daily equivalent of enalapril or more than 160 mg of valsartan, then we can directly start from 100 mg twice daily of ARNI. But in our Indian population, we see that the blood pressure remains very low in HFrEF patient. In our patients, we should be very careful and we should look for the development of hypertension once we start with these drugs. So preferably we should start with low doses. If the patient is elderly, then we should be more cautious. We can start even at a dose of 25 mg once daily. In many of my patients, I have started those patients where the blood pressure is on the lower side, like 90 to 100 systolic blood pressure. I have started with a dose of 25 milligram once daily of ARNI. Then gradually, after, waiting for 2 weeks, 2 to 3 weeks, then I try to increase the dose. And eventually, if possible, maximum dose is 200 milligram twice daily. So if possible, we should prescribe at that dose. So then when to consider ACE or ARB? Of course, when ARNI administration is not possible. And beta blocker, of course, we know that beta blocker is another pillar in the therapy of HFrEF. So beta blocker, aldosterone antagonist, and SGLT2 inhibitor, we should introduce as early as possible. If the hemodynamic parameters allows us, we should initiate these therapies as soon as possible.